The following is an Operation Podcast production.
Women typically live longer than men, but they do live a significant portion of that in poorer health. From that 2002 through roughly, I guess you could say 2023 or 24, the percentage decline in prescriptions was 82%.
In what other leg of healthcare or drug has that ever happened? If anything, it's the opposite, right?
Correct. When we look at muscle, to me, muscle is the organ of longevity because it has so many functions, and we lose about 3 to 5% of our muscle mass per decade, but it's definitely accelerated after you pass menopause. Why? Oh, I'm sure it has something to do with estrogen. I don't know.
While over half of women aged 40 to 64 reported perimenopause or menopause symptoms, only about 8% received an actual confirmed diagnosis.
Yeah. Adequate training on menopause and perimenopause was never a very big part of what we learned, even as an OBGYN.
Are we saying here that these comorbidities are because of perimenopause and menopause, or being in perimenopause and menopause, you are more likely to fall victim to these comorbidities and other illnesses?
So it's not a direct cause. What our body relies on in the ecosystem in where it is optimized and functionality does its best is in the presence of estrogen to the levels that it is during your 20s and 30s. But it really is the body's ecosystem or equilibrium does take a shift with the decline of estrogen, therefore heralding the ability for your body to present with things that were maybe already there or didn't have the opportunity to progress because of estrogen being around. Hey everybody, it's Dr. Jessica Shepard. I am an OBGYN. I am a clinical advisor for women's health at P-Evolve and the author of Generation M. We have everything you need on this segment here for women's health and longevity, so catch this session on Ever Forward Radio.
I would like to first kind of dive into redefining women's health and longevity. So when I say that, women's health and longevity, what first comes to mind for you compared to what do you think comes first to mind for women out there? Is this even top of mind for most women?
I think actually it is not top of mind. And I think that has to do with the framework of how women were socialized, just the life that we live. I think it really is. We are so invested in taking care of a lot of other people rather than ourselves. And many times when we think of midlife, that really is that crux of time that we really get the opportunity, I'll say it as an opportunity to do some things a little bit differently in order to prepare for that next chapter of your life. And I think that in that, longevity really isn't one of the hallmark terms that comes to mind for most women. And I think it is rather new when you think of the industry in general of health and wellness, longevity. What does it really mean? And what do you think of quality of life and how you're showing up later on in life in your 70s, 80s, and 90s, right? We're living longer. Women typically live longer than men, but they do live a significant portion of that in poorer health. So how can we reframe those last few years to be more functional, to be thriving is really what we do now in midlife.
I love it. And this is exactly why you're here. I love how you kind of already are reframing health through a mindset lens, looking at opportunity.
Yeah.
Before we get into all the other scientific goodies, start with mindset, start with this opportunity. How could you maybe help the woman listening or the partner listening right now who is struggling with, their partner is struggling with just flipping that switch or getting into no matter what my health situation is or is not right now, I do have an opportunity to allow it to continue, or I have an opportunity to change it or to get ahead of it. How can we start with opportunity? How can we start with mindset first when it comes to our health?
Yeah, I think mindset is one of the key things that you have to focus on, because if you think of when we get to that time frame in our life, it usually is based on habits, routines, things that we've done for many years. And many of those habits and routines have to change. And that is easier said than done. And that's where mindset really is a big part of that, because we really need to change the mindset in order to then start the action, right? I always say that the mind is really what navigates how we do things and the body just follows through. And so if you can start there, then you can start to change some of the intentions that you have for yourself or the routines and habits that you've already formed, which is why the brain is so good at what it does, but it loves routine and habit. So in order to change that narrative is to start with mindset first and say, how do I want to show up for myself? And usually it has to be very internal in order for you to continue in that progress of change. And then also community. I think that community plays a big part in who's there to support you and show up and get you through those rough days. But mindset really will propel your body into doing the thing that you want it to do.
I feel like I probably know the answer to this question, but I want to ask you directly. Was this something taught to you in medical school? Was mindset ever, was it an elective? Was it a part of a seminar?
Yeah.
Where did this come from for you if it wasn't taught?
Yeah, it definitely was not a course or an elective rotation that we did in med school because, I really honor medicine for what it is and the amount of years that we spend really studying very furiously and very intently for so many years, like 14 years. Most people will say that when they started the whole process of medical and pre-med going into, fellowship, all those things. But what we do focus on is the art of pathology, right? And when someone is outside of a quote unquote normal phase, right? We're really good at fixing bad and we're really good at fixing pathology and abnormal. And what we haven't been taught, and for good reason, because when people do go in that category, most people don't know how to fix that. So that's what we're there for. But if we can change the narrative to how can we allow people to be more in the well space, that is, I think you could even think of all the different obstacles that people have to stay well. There's a lot of them out there. And I mean, we can go into a whole nother section of nutrition alone, right? And so I think that we're not taught that. I think that we could do a better job, and I do see some improvement there, but that will take time to get to the point where a physician truly understands the well span versus pathology. Now, for me, I think that's where I'm a little bit different because I had a background in exercise physiology. So I truly understood the mechanics of the body and what the human is capable of doing with effort and seeing at its best what someone can do as far as performance and enhancement. And so once you have that background, I think going into medicine allows you to have a framework for something that people can accomplish and achieve. And even in the light of pathology, there still is that light of what you can do outside of that. And so there was always kind of this hope behind, how I practice in bringing out the best in people. I would say, even in my practice now, it is the hardest part of my practice is inspiring people to turn that narrative around or to partake in the things that's really going to help them in the long run. Consistency is key, but it is hard work.
We're kind of just hitting on it, but even people that are, air quote here, you're in good health, you have good health, thank God. There are barriers to that of staying well, or, you get a sickness, an injury, and then, you have to deal with it. But I think it's even more difficult for someone now who is a type 2 diabetic, who maybe is in a less than ideal socioeconomic status, or the whole world of nature and nurture. You grew up not knowing any better. And so what is your perceived norm is objectively unhealthy. So for someone who is not even in the well state yet, can you kind of just want to go a little bit deeper there? And, because I think for them to hear a doctor go, mindset first, or mindset is a great place to start when trying to get well, regardless of age here. That's probably got to land a little odd to most people.
Odd. Yeah, I think most of
so we have to convince them a little bit more, right?
Oh yeah, we got to find different ways to draw them into this realm of wellness, because it really is a different feature to how you live, right? It really comes with planning, being intentional, and setting kind of goals for yourself. So typically I always love, I love this saying is that curiosity breeds growth. And sometimes just, a few more questions or reading just a touch more, it doesn't have to be overwhelming, but the more that you crack at what is behind the curtain of wellness, I think that that's where you can be inspired to find what works for you. Staying authentic to who you are, whether it's like a cultural thing, whether it's what my community is, right? You can still stay true to that while still getting into the scope of wellness. And I think that's one of the misnomers that I think is out there, is that you have to be a certain size, frame, category in order to achieve the best in wellness. And I think that is something that can prevent people from wanting to get into that space, because there's a fear of it, or there's a notion of, I don't look, sound, feel like that, so therefore I can't do that. I think one of the best ways for people to see wellness at its like grand stage of whoever you want to be and you can still accomplish is like the Olympics. Like, think of the difference in body shape, size, characteristic of all these different athletes who are accomplishing like these major goals. And you would be like, I never thought that they would be able. I did. And that is, I think, the underlying theme of wellness that we should embrace, rather than it has to be a certain thing. I'll give you an example of like yoga, right? So yoga, its fundamentals are from India, right? And when it was kind of, I think, modernized or brought to America, it was great because it really is mindset. But then it became more of an exercise, which is fine. I actually don't have a problem with that, but kind of chipping away from like the intention of it. And then it became a certain type and a certain look and a feel. And then it actually became more inclusive or exclusive rather than inclusive.
Right. Yeah.
Right.
Yeah.
And so now we're seeing kind of a shift in that, where anyone can do yoga, which was the intent anyway, right? And it really is based on mindset. And now we are coming back to that in mindset first, and then really nurturing that so that your body reaps the benefits of that too.
Where do you think most women are right now in America, we'll say, when it comes to, I feel like I have good wellness, I'm not in disease, or even if I do have an ailment or an illness, I'm navigating it in some capacity. What do you think is the general mindset of most women right now in America when it comes to their health and wellness?
I would say if you looked at it from the entire population, I wouldn't say that it's categorically well. I think that there's still so many barriers for women that is not their fault that prevents them from entering into the wellness space. And
like
so
what?
that can come from being the primary person who has to do all the caregiving at home, whether it's with children, whether it's with older parents, managing. If there is now a career woman who's like really reaching her heights in career, we have seen already that even from economics, if you want to bring it down to an economical standpoint, they are paid less on the dollar than a male, right? So there's that, where they're not getting the full benefit of their return on investment for their expertise. And most times I would say women who are in a career and really rising still have yet the burden of the home to take care of. So in that, what I have found is that women who do want to try their hardest to be, just do a little bit more for themselves in wellness, then they have constraints of what is the expectations for them to fulfill in their home, the barriers that we just talked about with childcare and career, aging parents. And so I do feel that there is a category of women who do want to do that, but it is a little bit harder for them to accomplish it. And then for women, if you think of, we had mentioned it earlier, in maybe a less socioeconomic standpoint, don't have the capability to do the thing that they would want to, or even knowing that it's there. So I think exposure is one of those big things.
Yeah, that's so true. That's so true. Where do you see currently the biggest gaps in how healthcare supports women in general, before we even get into perimenopause and menopause?
Oh, we're going to do this for a whole nother hour. No, I'll shorten it. I actually was at a round table very recently with women who are at the top of their game in many different sectors, whether that's with VC, financial, retail, health. And one of the things is that we know that there's a major gap in women's health, and that can be even from the level of research. Women were not typically held in research projects up until like the 70s.
Meaning like actually contributing to the research?
In the research.
Part of the study?
Part of the study, okay. Right? So the physiology of women is drastically different from men. So in order to understand the physiology and the pathology of women, they have to be included in studies. So there was a lack of that. I think even when you look at what is the expected, whether it's a medication dosage or a reference range for a lab, many times women were not included in that. And so it is hard to man their health overall if they weren't really inclusive of research. I think when you think of innovation for women, when you look at VC funding, I think it's only 3% go to women founders.
Still?
Yeah.
Wow. Geez.
Yeah.
That's nothing.
It is nothing. So, like there's barriers. So then now there's funds, there's money, there's research. And I'll give you another example. When you think of the pharma industry, in the last 10 years, most of the top pharma companies have obliterated their women's health divisions.
Obliterated. That's a big word. That's a harsh word.
So you can have a whole sales force. You can have a whole team that's devoted to outcomes on what women are doing on their medications, right? So looking at outcomes. So they may still have the medication as part of their portfolio, but there's no engine behind it as far as who's going to get it to the right physicians or how the ads are placed or who knows what's out there. So I think there's so many barriers, especially when you are able to see that, in the forefront, because I've been part of those industries, trying to propel them forward, and then you see the obstacles. And so I think of being at those tables and in those meetings and seeing the obstacles at the level that we're speaking at it. And I can only think of the women who have no idea that all of these conversations are going on, or something was taken away, or that research wasn't offered to women, as early or as late as the 70s. So they're just kind of trying to survive day by day. And all these decisions are being made about their health and they have no clue. Yeah.
It reminds me of, there was a show recently, I forget what it's called, with Brie Larson on Apple. She was this budding biochemist, I think, PhD, I think in like the 60s or 70s, and was all around this whole aspect of getting shunned from research, even though she was quite literally the primary contributor. She wasn't even, I think, like in the top 5 names of like this study or this work. So hopefully times are changing with that.
Yeah, I mean, I think the only way to really push that forward is to stay present and to be optimistic, to be advocates. And I think that's where men really come into the circle of how we push that forward, is to be advocates and adversaries as well.
Absolutely. Well, let's get a little away from like health policy and the behind the scenes, and I want to really help my audience, myself even more, understand things like perimenopause and menopause. So what are the earliest signs of perimenopause that women, you think, often overlook?
Well, I want to frame it to what is perimenopause. I think that actually is one of the most confusing terms for women.
Yeah, define our terms, please. Yeah,
yes,
thank you.
Because we do know about menopause. I think most people, if you were to say menopause, what's menopause, are like, even if I don't know about it, I've heard about it. And menopause, I always like to define that first because it's easier, but really...
And then work backwards a little bit.
Yeah, that will work backwards. But menopause is a very clinical term. It's a diagnostic. It really helps healthcare providers to be able to define where a woman is in her reproductive state. And so the hallmark is they haven't had a cycle for 12 months consecutively, meaning that their ovaries are no longer giving enough estrogen off or estradiol to elicit a cycle. So that means they're at the end of their reproductive years. They can't get pregnant. They can't conceive. And the lack of estrogen is the cause of that.
Now, does this typically land on around the same year of age for most women?
It
or
is.
can it really
There's
fluctuate?
an average age of 51, but I have seen many of my patients who are 55 and still have cycles, right? So there's no, I would say most 51, 52, but you do have some who might end at 47, some at 55. And then kind of pushing it back to perimenopause is that confusing time frame, because it's almost like it could last 10 years, 7 years, 3 years. There's no definitive start to it. Wow. There's no end to it until you get to menopause. And so that whole time frame is when women start to maybe have irregularities in their cycle, right? So that's the estradiol kind of like going down and declining, as well as progesterone and testosterone, and also the symptoms. So I like to categorize it into 2 buckets: symptoms and cycles, right? So you may have a woman who has regular cycles, all the way up till she's menopausal. Most will have irregularities, right? So that takes care of the cycle bucket.
Irregularity meaning what exactly?
In their cycle. So it can be in frequency, flow, duration.
It's not always at the same time.
They could have it every 3 months. They could miss 6 months and then it comes back again. Or now it starts to be heavier. Sometimes it's lighter. It's just like all over the place. And you're just like...
That sounds wonderful and amazing. Kidding, of course. But you caught me right there. You said it could go even 6 months.
Yeah.
I'm curious.
Without a cycle.
Without a cycle.
Yeah.
Is there ever a situation, have you ever seen a situation where that happens? That's a long stretch of time. And then the woman and maybe their PCP go, oh yeah, you're going into menopause, and like begin things like hormone replacement therapy or make changes too soon, and then it kind of comes back?
That's a great question, and we can kind of tackle that later is the treatment.
Okay.
And that's what has changed probably in the last 5 to 10 years of treatment. So we'll put that in a pause for now, because that's actually a really important feature that I want the women who are listening.
Yeah, because things like misdiagnosis, early diagnosis are a very real thing for everybody.
And that's why I like to put it in buckets. So the cycle kind of like, it can be regular or irregular. And then you have the symptoms. So the symptoms are when women can have changes in mood, irritability, decrease in libido, hot flashes, night sweats, sleep disturbances, changes in skin, itchy skin, ringing ear. So literally about 34 to 50 things that can happen. But it is not, 34 symptoms. And a lot of women don't connect the dots because we have kind of typecast perimenopause and menopause to the pelvis, right? But if you think about the body, going back to like bringing it all together, is that the body has estrogen and progesterone receptors all over the body. Muscle, heart, brain. And so when you decline the estrogen over time, that's when the organ systems are not going to respond as well because they're not getting the estrogen that they need. So that's why we start to see these symptoms start to occur, usually like very infrequently, not too severe. And then over time, it starts to kind of ramp up until they get to that point where estradiol is like, I'm out, peace out, I'm not here anymore.
I've heard my wife is she's an FNP and specializes in hormone health and functional medicine. I've heard her talk ad nauseum about just how most people don't get most women especially don't get the cardiovascular protective benefits of estrogen and estradiol. You kind of just hit on you know, heart health. Can you go back real quick and kind of paint that picture? Because still in America, and I think the world, cardiovascular disease is the number one killer of all people, not just women.
Yeah, all people. And I think that that is one of those statistics that really stops people in their tracks, is that we talk a lot, and for good reason, we talk a lot about breast cancer. We talk a lot about cancer in general and other diseases. But when you bring it right back to it, I'm like, heart health is imperative. And that's the number one killer of women and all people. So the reason why estradiol is pivotal when we think of cardiovascular health is that most women who die from heart disease die after the age of menopause, right? So after they have been depleted from that estradiol, and we know that estradiol is cardioprotective. We know that there are estrogen receptors on the heart. So it would only make sense that if you're depleting the body of something, that a hormone, which is a chemical messenger, helps organ in its functionality is not there. What do you have? So it ranges from, when we say heart disease, I think most people think of a heart attack. But when we think of heart disease, that really is the scope of now my arteries are getting more firm, right? So there's no more flexibility or distensibility within. So that's what leads to atherosclerosis. Now we have plaque forming, right? So then we have muscle strength and the ability for it to pump blood into the different chambers. That all decreases as well. So there's an aging component, but the aging is compounded with a decline in estrogen, which therefore you start to have this declining functionality of the heart muscle. Arterioles are starting to, and arteries are starting to stiffen and fill with plaque. And it's just like, it just keeps compounding. But estradiol is cardioprotective.
And these are all kind of what we call the silent killers, right?
Yeah.
Because it doesn't have to be, to your point, just a heart attack.
There's no sign of it. There's no like, oh my gosh, my arteries are stiffening today.
Yeah, when I'm like, I feel like my arteries are so stiff. You know, it's not that.
It's not that. Yeah, it's very progressive. And hypertension, I would say, is like the most silent killer because you don't necessarily feel hypertension.
Right. Yeah, well, until it's
killing
across
you.
a certain point.
Right.
Oh, excuse me, I lost my place here. Okay. How do you help women differentiate between, or how can we learn to differentiate between perimenopause, stress, and just other health conditions?
Well, I do like to embody and help women embody the fact that they all play a part, right? It's never just one thing that's causing just one thing. And so helping women be more self-aware of what's going on in their body, but also learning that mind-body connection. Because many times stress can then contribute to maybe the severity of a perimenopausal disease, or stress can somewhat place more anxiety towards a certain symptom that you're having. And so that's why I think it's so important. And when we look at actual mood disorders, anxiety, irritability, and depression, the ages of 45 to 55 in women is when we'll see an increase in that and more diagnosis. And that's when we see a lot more prescription or prescribed antidepressants. But when you think of neurotransmitters such as serotonin and dopamine, which really are our neurotransmitters that make us happy, they're our happy kind of neurotransmitters, but they also interact with estrogen.
How so?
Well, because they're both hormones and they all message each other.
Are they fighting for the same like neuroreceptor sites?
They're not fighting for them. They are helping.
Okay.
They're helping potentiate, right? And so when we think of thyroid, we see more thyroid disorders, and estrogen does have a connection to that as well. So they're all kind of talking all the time, communicating, kind of saying, you should be doing this. Hey, I'm going to do this. And then when there is a disruption in one of those hormones, it usually will impact the other hormone that it communicates with. And so we do
so it kind of
see
one has a downstream effect to all of them, most of them?
No, they just kind of all talking to each other.
Okay.
And so when you have a decline in estrogen, its ability to communicate with serotonin and dopamine
I see.
is therefore lessened. And that's when you start to see mood changes, irritability. And that's why we do have an increase in prescribed antidepressants. And they have shown in studies when women are typically on some form of hormone replacement therapy or menopause hormone therapy, you do start to see changes and shifts more towards decrease and decline of mood disorders. Yeah.
I mean, that makes sense.
It's all connected,
Right.
right?
Yeah.
It's an all body experience. And that's why I want to really help women understand that that's why those symptoms start to appear. That's why they start to occur, is because your body really is dependent on estrogen.
What role does hormone therapy, you were just talking about HRT there, what role does hormone therapy play in menopause management today compared to a decade or two ago?
Yeah, now we can take that pause button off earlier. I'll start with how it's different today than it was maybe 10 or 20 years ago.
I feel like just by having conversations like this, I feel like, I don't know, just because I'm in the wellness space, but I feel like we're having so much more education and just sharing of information. So that's got to be a start, right?
Yeah, it's definitely a start. And there's a lot of work to do because of the WHI study, which was done in the early 2000s, really put a damper on hormones itself.
Yeah, can we maybe bucket that one as well and come back to that?
Yeah.
That one's pretty mind-blowing as well, not in a good way.
Not in a good way, exactly. The horror story of the WHI. But from that, so it's kind of like when you think of like someone who has to take care of the press of something when it goes bad, we're just trying to like repair all the bad press from that. So now we're restarting the conversation. And that's why you're starting to hear about it a lot more. We have really good evidence and data behind the benefits of hormones. And that's why we're starting to hear about it more and kind of navigating women back to that space of hormones actually impact you from a symptom perspective, but also longevity. And when we look at the numbers, they're actually quite depressing in the sense that only 5% of women today are on some form of hormone replacement therapy. So there's a lot of work to do still. Even though we're hearing about it more, we really would hope, or, you know, when we look to the future, see that number increasing, because we definitely know the benefits of what a woman can get from HRT. And so how it differs is we look at it also differently. We don't look at it just for, categorically, we still look at it just for hot flashes and night sweats, right? Which is probably the most common symptom of perimenopause and menopause. And now I always like to put it in buckets again. I love putting things in buckets, kind of like separate it out.
I got to get some buckets here for the table.
Yeah, we got to get some buckets
we'll come back to this point and that point. Yeah.
Is symptoms, right? So we know hormones are going to dissipate or decrease the symptom that a woman is going through because we're replenishing. We're giving them a buffer of some type of hormone that the symptom was the symptom came because of the decline in that hormone, but also longevity. That one's a little bit more avant-garde, if you say. Not many doctors are talking about the longevity aspect of it, but usually the symptom perspective of, which is why, to what you were saying about perimenopausal women being on hormones, or if they missed a cycle for 6 months and they were put on hormones, that's okay. We've changed. That's one thing we've definitely changed in the last 10 years. Before, I remember when I was training, we would ask a woman like over and over, are you sure you haven't had a period for 12 months? We were just wanting to make sure that they were menopausal in their diagnosis before giving them HRT. And now my women who come in their early 40s and they're having these symptoms, I'm like, this is quality of life. This is a symptom. Let's put you on HRT.
Yeah. So now can we go back to the WHI study?
Yes.
It was the Women's Health Institute or
Women's Health Initiative.
Yeah. Initiative, excuse me. It happened, like maybe a decade or so ago?
It was, that was 20 years ago. It doesn't feel like that long
ago, but it was
20 years ago.
So walk us through, when I remember now looking back, when it came out, it was a very landmark study. It was very progressive, but it kind of steered the ship in the wrong direction for women, for women's healthcare. For what reason?
The reason was, so this was a great study. It was up to 40,000 women that were in the study. So it was like landmark in the sense of
huge for any study.
When you have a power that big, I mean, you know that you're going to have outcomes that are going to impact a wide population of people. And so that was a good start. I think the intent of the study was phenomenal. And the study was actually for a cardiac-based study. It was looked at heart health, and it was looking at the impact of hormones on heart health, right? So it was from a cardiovascular perspective. In the study, they had many arms, right? So they had arms who were, meaning people in the study who were on this certain drug. Some were on estrogen alone, some were on estrogen and progesterone. The downfall came of that study when every study has like a limit. When you think of what is the limit of what we will say this needs to be looked at, the study may need to be stopped. We really need to look into that, which is what every study should have. And in the breast cancer category, and also for cardiovascular incidents such as stroke, cardiac events, there were increased levels of that. But you have to know how to read a study, right? That's the most important part is what does the study show? What is the relative risk? So going into epidemiology. And we're not going to do that today. But they stopped the study.
Yeah.
And from that, what came out, it was a lot of media like sound bites. Estrogen causes breast cancer. And that's what people ran with and ran in the streets. I mean, like everyone was running in the streets, like, get off estrogen. I mean, even healthcare providers, that's all was being spread around. Stop the, I mean, women
doctors
were
stop prescribing it.
Stop prescribing it. Do you want to hear the statistic behind that? From that 2002 through roughly, I guess you could say 2023 or 24, the percentage decline in prescriptions was 82%.
In what other leg of healthcare or I can't talk today, excuse me, drug has that ever happened? If anything, it's the opposite, right?
Correct. So there was a significant drop. I mean, I think in the education perspective, from like a healthcare perspective, providers, they weren't really given like the fundamental reasons on what was found in the study until years later. And so kind of that knee-jerk reaction was patients were like, I'm coming off, healthcare providers like, I'm not writing that. And then it just stopped. And, you know, I think it's long enough that we can say, let's put that to rest and move on. But women still come into the office and saying, is this safe? Which is a good question. Will I get breast cancer? And so now the education has to start in how to kind of give them contextually, because I can't go into statistics about it, but contextually what that is. So I would say 3 points that I usually give when someone has that fear is, we already talked about it. Yeah, there was a significant, no, it wasn't actually even significant. It was not a significant increase in breast cancer. It was not statistically significant. The risk of you dying is more so going to be placed on cardiovascular disease. I'd be like, you can put breast cancer, you can put uterine and ovarian cancer together in the same bucket. Heart disease will still win, right? So there's that. And also when we look at the main reasons why women have long-term disease or die from later on in life is dementia, cardiovascular disease and osteoporosis, and they break a bone, a hip, and then they have a really sharp decline in quality of life or living, all cause mortality. And one of the things that helps those things is estrogen, like directly linked. So I always put it back in their space of, here I'm going to give you statistics and truth and fact. You get to decide. Because if they still walk out of that office after having that discussion and they still don't feel like they want to start estrogen, I am still okay with that, because at least I know you know what the truth is. Now, if you decide I want to, then at least you still know the truth. At the end of the day, you have that self-advocacy to decide what you'd like to do.
What do you think it's going to take now from a public health initiative, from a provider level even initiative, of kind of rewriting this, I'd say even misinformation, but just rewriting this whole new narrative of estrogen hormone replacement therapy for women, because it kind of left such a bad taste in most of the public's mouth.
Real bad taste in the public mouth. I think there's two things to that. I think we have started to see it in the consumer side, and for women who are just like, oh, I heard about estrogen now, can I get it, right? So there's that kind of push from them going to their providers, but then also now we need to educate the providers on those statistics and how the benefit outweighs the risk by any day. I even have patients who have had breast cancer, and now because of whatever treatment they've been on, maybe their ovaries removed, and everyone's like, oh my God, don't go on estrogen. They're like, I can't live like this. I can't live with these hot flashes. I can't live with this irritability. I'll take the risk. Right? So it always is, there is a risk with everything. You get to assess that risk for yourself personally and decide, do I want to take that risk? I mean, we bungee jump. I mean, we jump out of planes, don't we? There's risk with that.
I love jumping out of planes. I love jumping out of planes. Yeah.
Right? So everyone gets to like have a risk assessment. What's that movie where he, like, it was a funny movie. It was Ben Stiller, and he was the risk assessment.
Oh, Along Came Polly.
Thank you.
Yeah.
Right?
Yeah.
So I think like that's how we get to live our lives. That's a sleeper
comedy, by the way. Pause this podcast and go watch Along Came Polly. It was so good.
I thought it was a great movie, but his whole thing was like, how much risk is assessed with this like one activity?
Assess the risk of this like Australian thrill-seeking CEO.
Wasn't it like Ben? Was it, what his name? Owen. What's his name? Who was the guy who was always? Oh no, it wasn't him. It was just some random. It was
some other guy.
But he would be like, "I'm jumping off a building right now."
His meet and greet was a base jump in like the opening line. Yeah, spoiler alerts. But it's so true. And this is, again, I hear my wife talk about this all the time, because I think this is an important through line for women, perimenopausal, menopausal, but for everyone. When looking at your health, your life, it has to fundamentally all come down to risk versus benefit. Risk, and that is so, I think objectively we can say some things that are in each of those buckets for most people, but ultimately, I'm not you, you're not me. We know what our quality of life, when it's on and when it's off. And using that information to drive the rest of our information with our provider of epigenetics, family history. Am I sedentary? Am I active? What's my nutrition? What's my sleep? Use all that to make a more empowered and informed joint decision with your provider or team of clinicians in some capacity. It has to be this, what's best for me.
It's a balance. And here's what I always say. You can start HRT, MHT today, and in 2 years decide you don't want to do it. You get that choice. Or you can not start today, and then in 6 months being like, you know what, let me get on that HRT. And I'm like, great, let's do it. You get to change your mind.
I did that. I was on TRT for about 14, 15 months. And I've been off now entirely for almost 2 years, or at least that, like 18 months.
So tell me, like, what was your decision-making process?
So for me, it was, I think for a lot of guys specifically, but I think, women as well, it was just a drop in motivation. I turned 36. I tell people I didn't start feeling 30 until I turned 36. And it was decrease in motivation. It was taking me way more work in terms of physical activity, sleep, exercise, nutrition to maintain my preferred body composition, to keep muscle mass. I mean, I've been in it personally and professionally in the health and fitness game for 2 decades. And I was having to just like sit down, hype myself up so much just to get off my ass and go to the gym.
And that's the same thing that women feel, and testosterone is great for them as well. Like the same features that you were just expressing. And so again, like quality of life, you were like, what is going on?
Yeah. So it was that coupled with, and I got my labs because I know how I felt. I wanted the qualitative and the quantitative data, and they weren't terrible. My T was, I think, in like the mid 500s.
Yeah, so that's not bad at all.
It's not
right?
terrible, but
Yeah.
my free T was on the lower side. My sex hormone binding globulin was on a little bit on the higher side.
Right.
So I wasn't able to maximize most of what I had.
So your
in there.
conversion and then your kind of like absorption to the
Right.
globulin there was something awry there. Yeah.
So I went on TRT. I forget my exact dosage, but I tiptoed in. It wasn't anything crazy. I titrated. I did it like, twice a week, or I guess you could call it microdosing tea for a little bit. But then I got amazing results. My motivation was back. Body composition was there. And those were my two main things. But then, like anybody, well, I think a lot of people, this is an important factor as well. Your goals can and will shift, especially as you age.
Right.
So my drive for wanting to go to the gym the same frequency, my drive for motivation shifted into fertility. My wife and I wanted to start getting pregnant.
Yeah.
And with T, there comes the risk
Yes.
of decreasing, especially for men, fertility, lowering sperm count.
Right.
And so I always played it safe because I knew we wanted kids.
Yeah.
So I titrated off, I lowered the dose, and then I went on what's the medication? Enclomiphene, yes. I did that for 90 days and then off entirely. And then now, boom, I have a 7-month-old.
That's great.
Yeah.
Do you see that? Decision making at its best, risk and benefit analysis at its best. I love that personal story.
Yeah, thank you. I try to weave in my story a little bit,
that's
into
great.
a
Because
lot
I think,
of this stuff.
I think in the expert field, when, people may listen or hear or be in company of that, the personal stories really matter. And so that's why I always share like my story with patients. And, I'm on hormones as well.
What is your story?
Yeah, I think, for me, being perimenopausal, being almost 50.
We can cry later. I turned 40 in a few weeks.
Yeah, I'm
so
almost 50.
we're almost hitting those next decades together.
I know, we're like hitting it. And so my first symptom, which is funny because like this is like my wheelhouse. Again, it's like those subtle things that start to happen and you're like, wait a minute, did that happen? Did this happen? And mine was cognition. So being able to remember things, multitask was probably, or concentration, like you're literally talking to someone and either like forget what you're talking about, forget a word.
Just kind of like blank mid-sentence kind of thing.
And you're just like, that was a thought when it was there. And I just, after some time, you're like, oh, then you start paying attention to it because of the frequency of it. So I was just like, that's so weird. Maybe I'm stressed. You go through the whole thing. Maybe I'm stressed. Maybe I'm too busy. And then I was like, holy shit. I was like, I'm perimenopausal. And so my first actual introduction to hormone replacement therapy was testosterone because I knew for cognition, I knew that that's where we do really see some benefit to testosterone. I think a lot of people only associate it with libido. But for me, I was like, all right, well, I already work out a lot, but I could maximize some of my muscle building potential, but also the cognition. And so I started out with testosterone and then, and I didn't really have hot flashes nights, so estrogen is amazing for. But remember we were talking about the buckets? I was like longevity wise, I want to be able to kind of start the process now. And so I started adding estrogen in my therapy regimen with
Around
the testosterone.
what age was this for you?
So if I'm 48, so it's about like 2 years ago.
Okay.
So it's about 46. And I noticed the changes in my energy and in the cognition in the areas that I spoke about. And then in estrogen, really for me, it wasn't for symptoms. So I haven't really noticed a change in a symptom because I never really had one that was specific to estrogen. But I do know, and I'm sure you've heard of that study where I think it's 44, 46, and then 65, where you have these main things in your life where you start to change your epigenetics, like the aging process kind of like really curtails. Yeah, so they've identified 2 ages at which kind of like, if you're to look at a graph, like your decline of aging, I mean, so your cells start to age, your organs are like, why are we still here? So that hallmark is, I think it's 44 or 46, and then again at 65, I believe it is, that your body starts to take like this toll, like another big significant decline in the aging process. And so I knew I had just passed that. And so I was like, let me maximize as much as I can. And you know, in the supplements, I don't take a ton. I'm not like a supplement whore, but
I am.
You're a supplement
I
whore.
am, yeah.
I want to hear about your
Yeah.
regimen when we finish, but I focus on vitamin D because my D was very, very low. I focus on creatine, again, for working out, but also for brain health. And then sometimes I'll dabble in like CoQ10. I would say I'm just not the best consistent person, but
Yeah.
CoQ10 and then urolithin.
Urolithin A?
Is probably my 4 that I focus on.
Love it. We're in the
Yeah.
same company. I take ubiquinol for CoQ10
Yeah?
daily now. I've been taking urolithin A, probably pushing 3 or 4, almost 4 years.
Oh, wow.
Yeah.
Yeah, I think I'm only like about 8 months into it.
That for me was probably, and actually I went off of it for about a month and a half, almost 2 months to kind of do a self-test. That for me was the biggest mover in my
Really?
daily baseline energy above anything.
All
And
right. Well, I'm gonna make sure I'm more consistent with it.
it's so
since you
good.
said that.
It's so good. I got some, even the brand I use, Timeline.
Yeah, I use Timeline too.
We got
But
their
I
gummies
didn't-
out here.
Oh, I already had
They're
some.
so good. They're so good. Yeah. See? Doctor approved. And, shout out Timeline because actually, and they are a partner, the sponsor of my show, but I love how they waited to come to market. It was like 10 years. They now have, I think, 12, 13 years of human clinical evidence
Their
showing
evidence
the
is
efficacy.
great.
Yeah. it's
I would
incredible.
definitely say that. And I've looked into their products, and then so I have the powder, the pills. But
Yeah.
maybe I need the gummies now.
The gummies are great.
Yeah.
I'm a supplement whore, but also a gummy whore. I love creatine gummies, any of that stuff. Yeah.
Now we know too much about you, huh?
This has got to be HIPAA compliant. I can't give up any more. So speaking of, let's kind of get into the science of longevity and healthy aging here a little bit. What is some of the latest science telling us about women's health span and how we can extend it?
Yeah, I think so. There was a pivotal study which I help my patients with because it kind of falls into like the GLP category is when we look at muscle. To me, muscle is the organ of longevity because it has so many functions and we lose about 3 to 5% of our muscle mass per decade, but it's definitely accelerated after you pass menopause. Why? Oh, I'm sure it has something to do with estrogen. I don't know. And also testosterone. Testosterone takes a steady decline from the age of 35 in women, right? So you have the steady decline, then estrogen kind of like falls off a cliff at, when you're 51, 52, but it was already on the decline through your 40s. So if you know that muscle mass is starting to decline in your 30s and 3 to 5% per decade and then compounded, after menopause, the goal is to, how do I restore muscle as much as possible? Because that's going to help with your glucose control. It helps with cognition. It definitely contributes to maintaining that muscle strength and the bone muscle complex so that you don't have frailty issues when you're older. And so for me,
women really have to worry about bone
do.
density, sarcopenia.
Absolutely.
And you can really alleviate that by focusing on muscle-centric.
And that's why I was talking about the compounding of muscle loss after menopause is because not that men don't lose muscle mass either, but they don't go through that kind of critical point of menopause and estrogen loss, which like really curtails the loss as well. And so I think that one of the biggest things I've tried to impart on myself as well, but like my friends and my patients is really resistance training, strength training to build that muscle mass back, to kind of go against that sarcopenic change, to go and help you with your glucose management. Because glucose to me is that wheelhouse of how our body functions. And when it can't metabolize glucose and when too much glucose is lying around, that's when your body's not utilizing it as fuel. And that's when it's sitting there. And when it sits there, we all know it converts to fat. So I'm like...
And things like diabetes.
Absolutely. So it's the control of it. It's making sure that we're staying strong, but also helping with brain health as well. There's a big impact on muscle mass and brain health too.
What would you say right now, pun intended, the first thing that comes to mind, the biggest thing that comes to mind when we're looking at muscle mass and brain health, particularly for women?
Yeah, so the brain health comes with a lot of the neuroplasticity that we were talking about. So as your muscles are staying strong, so your movement, right? So it's more in the movement part of what your muscles are able to accomplish that's going to fire to the brain to do that movement, right? So we typically, as we start to get older, become more sedentary just from nature, biology. I think a lot of it has to do with society. I think the westernized society in general, because if you look at
you're aging, slow down, take it easy.
Take it easy.
Yeah. No, we should actually be encouraging the opposite.
Absolutely. Because when you look at blue zones, the people that live the longest and the healthiest are people who live in areas where they have to what? Move. It was all about movement, was what kind of sustained them in the aging process. And so that has a lot to do with balance, flexibility, posture, and then learning movement. Your brain to remember the movement is enhancing your cognition and your ability to kind of like fire off the neurons, which keeps them young.
Beyond avoiding disease, how can women thrive physically and mentally in their 40s, 50s, and beyond?
Mindset, we've already, started our conversation with that as mindset. And I do think that there has to be a shift in how women see themselves. I think if you think society or societal pressures on women have been to their worth, like I guess you can say, and not in a good way, is placed a lot on reproductive years, right? Like kind of like that's what they're, obviously men can't have children and that's what we're really good at because we can do it. But I think we've placed almost like a price tag on it in the sense where if you think of career, even if you think of Hollywood, right? And actresses have said this, like after a certain age, and it usually kind of like is right with that reproductive time frame ending, there's a lot of decline in confidence, worth, what your value is. And so with that comes, mental kind of like, what am I here for? What am I useful for? So then you have kids leaving the house, right? And so then there's now to take care of elderly parents. And so again, that shift is away from focusing on them personally while all these things are going on biologically. So it's this really like pivotal time that we really have to change the narrative of you have an opportunity to really allow the second chapter of your life to be vibrant, but it's going to take some work. And that's not always the fun part, but it's so worth it.
What do you think is one thing a woman's partner can do that is not only just going to be supportive, let's say, perimenopause or menopausal, but what can they actually do? What can I do for my wife when she gets to this place in life that is actually going to move the needle and help her through this next, health era?
I think a lot of it has to do with emotional capability and emotional distensibility. Because as women, we talked about it earlier, but the irritability, the mood changes, right, is something that can occur. And I think the strengthening during that time frame from the mindset has to do with these changes in emotions. What is my worth? Does my partner see me as the same person? Is to be that emotional support and not to fix. I think men are really good at fixing things, like they want to fix it.
We think we are. We try at least.
I mean, I was going to let you say it.
We try.
But I think, just being that emotional support and how can I help? How can I best help you through this time frame? Or even being supportive in the physical feature of it, of let's go take a walk together. Do you want to work out together? Or is hormone replacement therapy something that you would like to start? Because I'll support you in that, right? I think the support is sometimes something that we want, but maybe don't voice it as well as we should. Or knowing how to voice that. And I also think that for so long, this is where I see most of the issues between partners when they come in to see me, like a woman who's like, I don't know if I can do that, or is because we have created this, that it's icky and like taboo to talk about this change, right? So most women will be like, well, if it's taboo already, I'm not gonna bring it up. And so they suffer in silence. And I think that's a kind of like a mismatch for people who have partners and spouses, is that intimacy of what is going on with your life emotionally is missed. And then a lot of times when that emotion part is missed, some of the other layers start to fall apart.
I want to go back, if I can, and revisit your first tip there of emotional support for the partner to be more emotionally supportive, to be there more for their partner. Can you I want to dig a little bit deeper. Can you kind of explain scientifically, what are we actually doing? By me being there for my partner, by me being more emotionally supportive, help me understand from a scientific level, what is that actually doing for my partner? So maybe, because sometimes when we understand how and why things work, it kind of just like anchors in a little bit better. So from a scientific perspective, what is going on with my wife when I am there for her more?
Yeah, asking the question and lending the support instead of having them to ask you, I need this, is I'm coming to you to shoulder this burden, to kind of help take the burden off of her of having to think it through, or who should I tell? How do I tell? So there's that. And it's kind of like a landing place. But in that, what happens is we've seen in science the connection when people have emotional intimacy allows them to strengthen their ability to accomplish the task. Right. And so that we see that as people age, or we saw that during the pandemic and where we saw isolation.
Oh, yeah.
Right. Yeah. Isolation, feeling like displaced. I don't have anyone around that kind of emotionally is just there, can create a lot of physiologic damage or physical damage. Right. And so I do see that women, so this is out of the context of perimenopause and menopause, is when we think of like chronic pain, any chronic pain syndrome.
Like
lot of times,
fibromyalgia, kind of
all
stuff,
of that is a lot has to do with what is the support around that, and who is there emotionally for that person can help alleviate some of that pain, right? And so that's where the mind-body connection comes in, and being able to support the mind so that the body can do better.
Yeah, great. Thank you for that. So we touched on, perimenopause. Can we kind of shift gears into, the next stage?
Yeah.
Menopause. What's going on there? Is it, these signs and symptoms, the age, all of this stuff? Walk us through menopause a little bit more.
Yeah, menopause, we said that kind of categorical age, or the average age, is 51 to 52. And so this really is where the ovaries are like, we're peacing out. We're not giving really any estrogen. Best of luck to you. We're not really doing anything anymore.
Thanks.
Right. And you were like, but you were so good to me. So from that time of menopause on till the day that a woman dies, they are postmenopausal, right? So there's no, I'm out of menopause. You were just menopausal until you die. And that's why it's a clinical term. All it means is that you don't have menses, haven't had menses, and your ovarian follicles are not giving off estradiol. Now, typically in the first 2 to 3 years after reaching that menopausal age for any woman, if they have symptoms, that's usually when they'll intensify in the first 2 to 3 years. And that's why I was telling you when I was training, we'd always wait for them to be like, we're menopausal. And then we would give them, their hormone replacement therapy if they wanted it. And then after that, the body has a beautiful way. The body is a beautiful machine, and it really knows how to, I guess you could say, figure it out. And after some time,
homeostasis.
Yeah, homeostasis. We see that, that menopausal transition can occur from anywhere from 2 years, 3 years, to even as late as, when we think of symptoms, I'm talking about anywhere to like 11, 12 years. But they may decrease. Typically, they wane over those years, and then the body gets into homeostasis, where it figures out how to rely on itself without estrogen from a symptom standpoint. And the women will typically not have symptoms as severe. But the other part of that is the internal work on the cells in the body without estrogen over time is why we start to see disease progression, right? So their symptoms may go away. And I even have some women who are like in their 60s or 70s who still have hot flashes. So there's no like...
That's not common.
It's not
right?
common. Okay. It's not common. But it's possible. It's possible. I say the vast majority will stop within about 8 to 9 or 10 years. And they usually decline over those course of those years. But really what's going on, wreaking havoc inside the body from a cellular standpoint, from a metabolic standpoint, is the other part of the story that I think that we need to shed light on more. And that's what I try to really impose on when I'm speaking, when I see my patients, is we're training for a marathon. This is not a sprint. And how do we prepare ourselves for marathon is consistency, because there's a lot of stuff that is going on internally that we just don't see. But if you don't want the aging process to show up how you've seen it maybe in your parents or your grandparents, then this is the opportunity. That midlife time frame is that opportunity to being like, all right, marathon is starting now. I'm going to start training. I'm going to start small. I'm going to be consistent. But I know the outcome, the return on investment is so great.
I personally have done things as I've gotten into my mid and late 30s now to help maintain and even improve my hormone levels, particularly testosterone. For the women out there, what are some key nutritional and even supplemental factors that can really help maintain, preserve, alleviate symptoms? What can they be doing from those angles to help with perimenopause and menopause?
Right. So I go back to metabolic and mitochondrial health because those take kind of a hit as well. So when we look at glucose, I would say glucose is probably that number one kind of fuel or nutrient that we really have to pay attention to. And that can come in the form of what we're fueling our body with, in the form of food. And that's when I really start to look at what does that pie graph look like for women, and what did we do maybe in our 20s and our 30s, because we were metabolically more active. Movement, we were doing more, but our bodies also were like, I can metabolize anything at this point. So as that metabolic rate starts to drop, muscle mass starts to drop, is looking at how can I now increase my protein source in order to fuel the muscle and offset the sarcopenia that's occurring. And so I focus a lot on the protein aspect. I look a lot at the supplements because I don't want you to wait until you're completely deficient in something before I would start to, pay attention to it. And then how we prepare our foods. Obviously, we live in a westernized world where everything is very convenient, processed. And so the more that we can offset processed foods, and then also calories. When you look at studies as we start to get older, our body actually doesn't necessarily need as much caloric intake. And so how does that work? But I don't like putting that into the framework too early, because then what comes is that diet culture of that I have to restrict myself completely of nutrition. And I was like, that's not the goal.
Which actually can be extremely detrimental to
hormones. My God, detrimental.
Yeah.
I mean, the whole diet fad trend is like, that's not how our bodies function, right?
So I heard in that, paraphrasing here, lowering sugar, lowering
By
decrease.
Far. And alcohol. I'm saying that because I'm like, ugh, it's not fun to decrease alcohol. But I also
If you're a drinker.
If you're a drinker. But I will also say I am definitely not a doctor who's like, you can have no alcohol. I mean, if you have cirrhosis, then yeah, maybe. But no one, I don't think that's a good way to impact and find change in people is to completely, like, what diet works where, we've seen diets in the past decades where I'm like, wait, you can't eat what? No one can maintain that. Is it sustainable?
And then wait 5 to 10 years and it's back, and it's the opposite, right? Also, beside, going back to your point earlier of blue zones, besides the Latter-day Saints, one of the other common denominators in every place, every group of people across the world that are living to be 100 years plus, they consume alcohol.
Yeah.
They're not binging. They're not
limited
amounts. It's limited, and it's
Right.
with friends. It's with community, and typically they're walking to get there.
Exactly.
So it's not any of these silo things.
And
it's
that's
collective.
why I think the silo approach in how we deliver information today is so dangerous, because there's no complexity to it. There's no holistic view in how you're living your overall life. It's just very like, don't do this, don't do this. And I'm like, that's not helping anybody. Yeah.
I think, in fact, of all the centenarians, I haven't read Blue Zones in a while, but I think it's females in Okinawa, females in Japan.
Yeah.
They tend to there's a high percentage of them that live to be at least 100 years or more. And it's women who walk to meet together, I think daily, if not weekly, and they sit and talk shit. They talk, they spill the tea, and they drink sake.
Yeah. Isn't that amazing? I think that again is looking at the complexity of life itself and being able to still enjoy it while still having, limitations, but connection and community is a big part of that.
Yeah. So everyone's racing to drink sake now with their besties. So decreasing alcohol if we drink, decreasing sugar, increasing
sugar.
protein.
I would probably put sugar first.
Yeah.
If I were to name one thing, I was recently on a longevity panel with a PhD who has a lab, and they really look at things like exosomes and so they're looking at the aging process of cells, like the cellular aging process to like a microscopic. And one of the things that they've categorically said is like sugar, additional sugar in your diet, or like adding sugar is like catastrophic.
Oh, right. Externally, internally, everything.
Yes.
I mean, now that's how we get into type 2 diabetes, but what we now see as type 3, Alzheimer's, dementia, inflammation caused by things like excess sugar, glucose in the diet.
Yeah. And what did we say? Exercise and all. So that's what I'm saying. It has to be exercises, nutrition, and what we're intaking in our body using hormones, if you decide to, and then, the supplementation of other things as well. But it has to be more than one thing. And I think when someone focuses on just one aspect of it, the outcome to me is not going to be as profound.
Now, for women, particularly perimenopausal and menopausal, when we're looking at increasing protein, does the old adage still hold up of 1 gram per pound of body weight of protein or 0.8?
Yeah, I usually do like 1 to
recommend?
1.2
wow, I love to hear that.
per kg. What I will say is it is not easy to do. And so that I like to reassure women, because what we are hearing now a lot is a lot more about hormones, or a lot about protein intake and weight training, like lift heavy. But we have to put parameters around that, or teaching people how to accomplish it. So we can't just put taglines out there and expect people to just like by the next day rise to the occasion. Is because you can also fall into trouble if you just follow something, but you didn't do it in a safe way, or you didn't do it with really good knowledge base behind it. But protein increase to what your body should utilize is also, then you have to be exercising as well, right?
Yeah, it's not just, don't just like have the bigger piece of steak or slam more protein shakes without actually giving your body a reason and need for that excess protein. Well, I shouldn't say excess, but adequate protein.
But adequate protein, because also if you're just increasing your protein but not finding a way to utilize it or using it to actually build the muscle store that you're trying to get back from the loss, then you're not really doing the thing that it was done for. And then also what type of protein and how you're going to incorporate it throughout the day. Don't like do it in one meal. Make sure that you're trying to like push it throughout the day. So there's so many different things to it, but I just believe that when we say things as an expert is to give parameters around it, reassurance, and also guidelines.
So I found some recent studies, or studies at least, that have been published within the last 5 years that I wanted to kind of just share with you. And all this will be linked in the description box and show notes for you guys. I want to just kind of like share some recent, pretty wild American US data at least, and kind of get your take on it. And also, what maybe can we do to hopefully improve these statistics? In fact, a 2025 survey of almost 5,000 women age 30 plus revealed a high symptom burden and frequent clinical help seeking. This underscores really the early and significant impact of perimenopause. Another one from a 2025 analysis showed that while over half of women aged 40 to 64 reported perimenopause or menopause symptoms, only about 8% received an actual confirmed diagnosis.
Yeah.
How do those stats land on you, and how can we improve them?
Oh, I think that those stats are probably very realistic in the sense that in the healthcare community, healthcare providers, adequate training on menopause and perimenopause was never a very big part of what we learned. Even as an OBGYN, I think that was not the biggest part of our training, because it was a lot focused on pregnancy, right? Fertility. And that's why I always say that that's the time frame in which women are kind of revered. So after that, they're like, yeah, your hormones are going to decrease and you'll be perimenopausal or menopausal. Perimenopause, I think, is the most confusing part of that whole transition, because like I said, it could start at 40, 45. Is it a hot flash maybe here and there? Is it irritability? Is your sleep pattern disrupted? And so putting the pieces together, both from the patient historically giving context, but also for the provider to sit there and kind of sift away possibly other things that could be causing that. Perimenopause to me is one of those like diagnosis of exclusion, like making sure it's not something more serious, or obviously not being dismissed as well, which I think a lot of the complaints I hear from women is they feel dismissed. Because if you think about it, if you go to your doctor and you're just like, I just don't feel myself.
Yeah.
We're like,
yeah, don't ever say that to your doctor. If you already have enough problems with them already, they're just going to dismiss you even quicker.
Right. So there's this dismissive nature, and then women get frustrated, and then they're just like, who else are they going to talk to about it? Who could help? And so it creates this cycle of, I'm not going to talk about it. I was dismissed, and doctors being like, well, I don't really know what the complex of perimenopause is.
Yeah.
So it makes sense. I think that we have to give more, I think the word would be intentionality around perimenopause and menopause as not just a symptom of a decrease in estradiol, but a whole body experience. And we have to use that experientially.
Two follow-up questions for that come to mind for me. One, is a woman's primary care provider, just a family medicine provider, whether that's a PA, MD, DO, FNP, are they the best person to go to maybe navigate perimenopause and menopause, or do they need to be going to fertility specialists, OB? Is there a better provider, more educated provider to navigate that?
I think that perimenopause, when you think of women in general, it shouldn't be that they should have to go to their OBGYN. Do I think that we probably, as far as like a background and how we were trained, might have the most experience with menopause and hormones in general, but I don't think it should be just OBGYNs who are able to detect and diagnose and treat. Absolutely not. Is
there like a specialty or a certification a woman can look for with their provider to go, oh, like they've got some more training at least?
Yeah, absolutely. Okay. So when you look at the Menopause Society, it's online. They have I guess you could say a certification for people who, whatever discipline they are, they don't have to be OBGYNs who can get that certification, which means that they've taken extra time to learn in a course and passed a course to be certified in offering treatment modalities to women who are going through
That's good news. Yeah, that's great. Okay.
It is good news.
My other question from your original reply was, with a lot of things, we might share family history and go, oh, my dad went through this, my mom went through this.
Yeah.
With perimenopause and menopause, if a woman talks to her mother or grandmother to get that data, does that really play a role in what they can maybe expect in terms of when it happens, when it stops, and symptoms, or is every woman generation to generation really different?
We do know that typically when a woman is able to ask her mother and or grandmother, there are going to be similarities in the experience, whether that's like time of it occurring, menopause, any symptoms that may have been experienced by their previous generations. That can be definitely a good talking point to talk to them about. What we do see is that a lot of women, mothers, grandmothers, because it was not talked about, they didn't know they were going through it. Yeah. Either they were dismissed or no one was talking about it. So there is not good recollection for most women, and maybe I'm wrong for saying most, maybe for some women, of asking their mother, but like even in my experience, like it wasn't something talked about.
They can't even firsthand go, even though they lived it, like, oh, for sure, at 42. They have no idea.
Yeah. Exactly. Yeah. So, and then the other part of that too is epigenetics and environment, right? We are seeing shifts in the age of women going through perimenopause, what that experience is like, just because of, where we are in innovation, what we're exposed to environmentally. I think that there are some shifts in that.
Okay. Also have another question around, I want to get your take on some study around comorbidities and looking at women, particularly in these ages where perimenopause and menopause happens. Yeah. So a 2025 study focused on U.S. women from the Midwest identified that several conditions, including hypertension, hyperlipidemia, osteoarthritis, sleep disorders, thyroid issues, and more, increase in prevalence by 45% or more between ages 40 and 59. These are right within the perimenopause and menopause ages. Are we saying here that these comorbidities are because of perimenopause and menopause, or being in perimenopause and menopause, you are more likely to fall victim to these comorbidities and other illnesses? A
little bit more of the latter remark that you had there. So it's not a direct cause. What our body relies on in the ecosystem in where it is optimized and functionality does its best is in the presence of estrogen to the levels that it is during your 20s and 30s. So that's why we do see more comorbidities with heart disease, hypertension, hyperlipidemia, autoimmune diseases, and also joint issues, which could, technically fall under autoimmune when you think of rheumatoid arthritis. But it really is the body's ecosystem or equilibrium does take a shift with the decline of estrogen, therefore heralding the ability for your body to present with things that were maybe already there or didn't have the opportunity to progress because of estrogen being around. Estrogen is really a very potent anti-inflammatory. So that's why we see a lot of more inflammation. That's why we see that the glucose insulin ability for it to be in homeostasis is dysregulated, which causes more inflammation.
I see,
Or we look at glycans. Glycans are an indication of longevity. And when estrogen declines, you do see a change in glycans, which then can lead to the diseases that you were just talking about. So there is a really whole body physiologic shift with the decline of estrogen, and it does make sense. And I think that's why we're able to link this a little bit more to that time frame in a woman's life of perimenopause and menopause with the disease progression, is because now we're looking at it rather whole body than just a fertility pelvic issue.
Right, yeah.
It really is a so some even categorize it as a neuroendocrine dysfunction or disorder.
Perimenopause and menopause? Really?
Yeah.
Is that always the case, or only if certain things cross certain
neuroendocrine
thresholds?
in the sense of what it does for brain functionality. When we look at, there is a book called The Menopause Brain by Dr. Lisa Mosconi, a good friend of mine, and they have the data now that shows when we look at brain scans and MRIs and how the changes occur in the decline of estrogen in the brain matter is, again, having to do with brain health, cognition. And so that has a lot to do, again, with estrogen decline. So it's fascinating. I think we're at a really historic time frame in life and in medicine where we're able to really connect all the dots in a different way than we have before, which I think should improve the long-term morbidity of women, improving quality of life, and allowing women to give them the tools in order to thrive in the best way, especially when we see that the statistics of women in disease is really, really terrible.
Kind of getting towards the end here, makes me think, we live in a day and age now of a lot of information. A lot of people are doing some wild things with their health and wellness, particularly, no shade here, but in the world of biohacking, people can go pretty far.
Yeah, they can.
For their own personal wellness reasons and goals, but I think you'll find a lot of people will biohack, will supplement, will do anything they can to attempt to thwart getting an illness, getting a disease, injury, or even people like Brian Johnson, who is saying, I'm going to be the first documented human to be over 200, or he's like, F aging kind of thing.
Right.
Are we at a place, can we ever get to a place where you think women can biohack against or biohack their way out of perimenopause and menopause?
Two different answers to that. I don't think currently we're at the phase where women can biohack their way out of perimenopause and menopause. I think that we definitely are at a place where we can ameliorate some of the symptoms, but also improving longevity because of the estrogen and the testosterone and progesterone that we are starting to see, and starting at a younger age than we did, right? So it's kind of like we're allowing the tank not to get empty, and we're kind of facilitating it when it's in the yellow, the blinker is on, waiting, instead of waiting what we used to till it's empty. The other part of that, there is another biohacking feature that I think, for a lot of my PhD friends who are doing a lot of work in the ovarian function studies. So in the sense that they're like, how do we allow the actual natural organ of the ovary to sustain estrogen production longer than it has, right? So therefore, not looking at it from a fertility issue, which they could be like, oh, maybe people want to have babies at 60s. I mean, I wouldn't, but anyway.
You're braver than me.
Right. I'm not doing it. But for the longevity aspect of estradiol, how can that help, right? So there are a lot of studies that are looking at that. One of my good friends, she's based out of New York City, is looking at actually ovarian longevity. And what does that mean? So the fact that we're even looking at that as a possible way of, I guess you could say, biohacking is a way that you could look at it from a purely women's perspective. But I think biohacking can be done in stages and phases. I think that sometimes you can go a little bit overboard, but I do like the notion that there are people out there who are pushing the envelope, right? And I think that's what's innovative in science, is that you just keep pushing the envelope until something is studied, recognized, and then can be proven. Yeah. I think we're years out from, the days of being Brian Johnson, but I think that I like that there is the notion that it could happen. The other thing that I would say is the best biohack, and the only reason I feel that this is important to bring up is something that's sustainable, is exercise. To me, biohacking is as simple as exercise. as the clinical advisor for women's health at PVolve, we focus on that from a holistic standpoint, because there's a lot out there about exercise, but you want to be able to present it in a way that feels engaging, right? So the community, but sustainable, and not someone yelling in your ear, lift heavy, right? But you can attain that and you can get that. And I think at PVolve, we have been able to establish a real fundamental framework in what does this mean for you now, but what does this also mean for you later?
Couldn't agree more. I mean, I think whether you're a woman going through perimenopause, menopause, anybody, any human, if you prioritize or made exercise your only quote biohack, you really can't go wrong. You cannot go wrong. Barring anything like, injury or stuff like that. But a body in motion stays in motion and a body at rest stays at rest. So I would love to ask you my final question, please. This has been a great session on perimenopause, menopause, longevity. And so I feel a lot more informed, educated, and empowered about this area of, I'll say, my wife's well-being. I don't think I have to worry about perimenopause coming up anytime soon, but educating myself to help those around me is definitely a part of what I say, living a life ever forward. What can I do to learn more, apply more, and to move forward more in my life, and also help those around me? So collectively, we're all moving forward. Those two words, what do they mean to you, ever forward? How do you live a life ever forward?
Yeah, I think living ever forward is to allow for the pause and flexibility in your life as you start to learn more, right? The more rigid you are, the more that you were beholden to, just kind of the firmness of it, then that's sometimes where we don't grow. And so I've learned that a lot in my life. In the last 2 years, personally, in my career, is really leaning into the pause and the flexibility.
We have all of our power in the pause.
Yeah.
That's I think, what is it? Viktor Frankl, the moment between stimulus and response is where we have or give away all of our power.
Yeah.
Where can my audience go to connect with you and learn more about you, or maybe even pop into a clinic in Dallas if they want to become a patient or something?
Absolutely. Mostly on my social, Jessica Shepard, MD on Instagram. Okay. And then you can also catch me on PVolve, as their clinical advisor. We are really looking into women's health.
Are you leading classes?
I am. I actually am leading classes and conversation and education on that platform. So at PVolve. Okay. And then if you're ever in Dallas, look me up. I would love to see anyone who's in the Dallas area. Great. Or in even the Texas state, come and see me.
You're my second Dallas doctor I've had on the show in the last month. Dr. Tiffany Moon was on the show recently.
Absolutely, I know her. We actually, I hosted her during her book tour. We live very close in Dallas, and we know each other really well. Good friends.
So much fun. Dallas people are the best. The Dallas doctors, you guys are welcome back anytime.
Thank you so much.
Thank you.